Welcome to the deep dive. Today we're tackling a topic that's, well, it's rare, but it absolutely demands your full attention. Necrotizing fasciitis. You might know it better by its more dramatic name, the flesh-eating bacteria. Pretty scary stuff.
It really is. And for this deep dive, we're using those detailed MSRA revision notes you shared.
Yeah.
So our plan basically is to break these down, pull out the really high-yield bits, and structure it so it actually sticks,
Yeah.
whether you're revising or just need to quickly get a handle on this condition.
Exactly. And understanding this isn't just about passing an exam, right? It's crucial because NF is a genuine medical emergency. It moves incredibly fast.
Super fast.
And the tricky part is it can be really hard to spot early on. So let's dive into these notes together and really pull out what you need to know.
Okay, so starting with the basics,
Yeah.
what actually is necrotizing fasciitis? At its core, it's a severe bacterial infection and it spreads rapidly. But the key detail, the really important part, is where it spreads. It targets the fascial planes. There's connective tissue layers under the skin, around muscles and organs. The infection travels along these planes, causing, well, widespread tissue death, necrosis.
And that's where that flesh-eating idea comes from, even though it's mainly the fascia and the subcutaneous tissue getting hit initially. But it does affect the skin above and sometimes the muscle underneath, too.
Absolutely. It can definitely involve muscle. And it's just this race against time. Recognizing it early is incredibly difficult, but so vital.
Okay. And it's not just one specific bug causing it, is it? Their notes mention different types. That seems pretty high yield for understanding the variations.
Definitely. Knowing the types helps you figure out who might be affected and potentially what kind of bacteria you're dealing with. It helps frame your thinking.
Okay, so let's break those down. What are the main categories we should know?
There are 4 main types described. Type 1 is actually the most common. It's polymicrobial, meaning there are multiple different bacteria working together. You tend to see this one more in patients who already have underlying health problems. Think immunocompromised individuals, people with chronic conditions like diabetes, or patients who've recently had surgery.
Right, so type 1 often hits more vulnerable patients. What about type 2?
Type 2 is different. It's usually monomicrobial, caused by just one type of bacteria, specifically Streptococcus pyogenes Group A Strep.
Ah, okay.
And the really crucial thing about type 2 is that it can happen in people of any age, and that includes individuals who are otherwise perfectly healthy.
That's a key distinction, so it's not just the sick or vulnerable who can get this.
Exactly. It broadens the scope of who you need to consider this in.
Got it. And wasn't there something about marine life?
Yes, that's type 3. This one is often linked to exposure to seawater or marine creatures. It's usually caused by gram-negative bacteria, so it's also monomicrobial.
And how does that one present?
Type 3 is known for being particularly aggressive, really rapidly progressive, and you often see it in patients with chronic liver disease, interestingly.
Wow, okay. And the last one, type 4.
Type 4 is fungal. The notes mention Zygomycetes and Candida species specifically.
Fungal NF, how common is that?
It's rarer, but these fungal types are noted as having a very high fatality rate. So while we often think of common skin bacteria like Strep pyogenes or Staph aureus getting in through a cut or wound as the starting point,
Yeah.
knowing these different types helps you, adjust your thinking based on the patient's background and how the infection looks.
That makes sense. And that leads us nicely into risk factors. Knowing who's more likely to get this seems vital for keeping it on your differential list. What are the main ones highlighted in the notes?
Absolutely. If you've got a patient with a soft tissue infection and something feels a bit off, thinking about these risk factors is key. The NOS list, diabetes, that's a big one.
Right.
Immunosuppression, which can be from many causes, obviously.
Obesity.
Peripheral vascular disease, any kind of trauma or injury, even seemingly minor stuff. Intravenous drug use is another one. And just generally having a weakened immune system for any reason. These are all flags suggesting a higher risk for a really severe infection like NF.
So that classic example. Patient comes in, looks like cellulitis, but they're diabetic. Bam. NF jumps way up your list of possibilities.
Exactly. You have to think about it.
Okay, let's get into the mechanism, the why. Why is it so fast and destructive? What's the pathophysiology?
Yeah, what's actually happening down at the tissue level is, well, it's pretty intense. So the bacteria get into those fascial planes we talked about, and they start pumping out these really potent toxins. These toxins directly damage the soft tissue. Then the body mounts this huge inflammatory response.
Which you'd think would help, but...
But actually, it makes things worse in this case. The intense inflammation impairs blood flow to the area. It essentially starts to choke off the tissue's blood supply.
Ah, okay. So it's the toxins and the lack of blood flow.
Exactly. That combination leads to widespread tissue death, the necrosis. And because the bacteria are spreading so fast along those fascial planes, the necrosis also spreads rapidly.
And that can overwhelm the body.
Yes. If it's not stopped, this local destruction quickly triggers a systemic inflammatory response syndrome, or SIRS. The body's basically going into overdrive, and that can lead to organ dysfunction and failure. Understanding this process really drives home why immediate action is so critical.
Definitely. Now, one of the big challenges you mentioned is that NF can mimic other conditions, especially early on. The notes give a list of differentials, the things you might mistake it for.
And this list is gold for clinicians. You absolutely need to be aware of these mimics. It includes really common things like cellulitis or erysipelas, more superficial skin infections.
Right, the ones you see all the time.
Exactly. But it also includes things like pyoderma gangrenosum, which isn't even an infection. It's an inflammatory ulcerating condition. Then there's limb ischemia, just straight-up lack of blood flow. Compartment syndrome, where pressure builds up dangerously. Deep vein thrombosis, DVT, or thrombophlebitis, clots in the veins. And even osteomyelitis, a bone infection, if it's causing soft tissue swelling around it.
Wow, that's a broad list. So the take-home message for the listener here is, if you see a soft tissue infection, but it seems unusually severe, or the patient is way sicker than you'd expect, or the pain is just off the charts,
yes,
you have to actively consider NF, even if your first thought was simple cellulitis.
You absolutely must. Don't dismiss it just because it looks like something common initially.
Okay. And speaking of common, how common is NF itself? What does the epidemiology look like, particularly in the UK context, from the notes?
Right, so the notes give us UK figures. It is rare. We're talking about 0.2 to 0.4 cases per 100,000 people per year.
That's really not many.
No, it works out to maybe around 500 new cases across the whole UK each year. And it really can affect anyone, any age, any sex.
So rare, yes, but the consequences are so severe.
Precisely. Its rarity doesn't lessen its importance. The high mortality, the high rate of complications, it means you've got to be vigilant and ready to recognize it when that suspicious case does appear.
Okay, so let's focus on recognizing it. The clinical presentation. What are those key red flags, the features that should really set off alarm bells?
It usually starts acutely, comes on fairly quickly. But the number one symptom, the one the notes really hammer home and the one you absolutely need for revision, is severe pain.
Right.
And crucially, as we touched on, this pain is often described as disproportionate. It's much, much worse than you'd expect just by looking at the skin initially. There might only be a little redness or swelling, but the patient is in agony. That mismatch is a massive clue.
That pain out of proportion, definitely a key memory hook. What else should we look for as it progresses?
You'll see rapidly spreading erythema, the redness and swelling. Then as the tissue starts to die, you can get blistering, those fluid-filled sacs called bullae. And sometimes you might feel crepitus. That's gas produced by some types of bacteria under the skin. It feels kind of like Rice Krispies crackling when you press on the area.
Oh, right. Crepitus. Got it. And systemic signs.
Yeah. Patients often feel generally unwell, malaise. They'll likely have a fever, chills, basically signs of a significant systemic infection.
And the notes add a couple of nuances, right? Like the skin appearance changing and maybe fever not being there right at the start.
Exactly. The affected area can become obviously necrotic, turning dark, maybe black, forming a leathery patch called an eschar. And another tricky point is that fever and tachycardia, a fast heart rate, might actually be absent early on, or they might develop later. So you can't rely on those being present initially.
That's important not to be falsely reassured if they're not there yet.
Yeah.
The notes also lay out some stages of progression, which sounds useful for thinking about exam questions.
Yeah, it's a helpful framework.
It often looks a lot like cellulitis, local pain, swelling, redness. But the giveaways are that the pain is severe and constant, it doesn't get better with standard antibiotics for cellulitis, and the patient might start showing signs of being systemically unwell.
Good.
Days 2, 3. Things escalate. The swelling becomes really tense, and it spreads beyond the edge of the redness. You might see those bulla forming. That's a sign the skin's blood supply is compromised. The skin color can change, maybe turn grayish or dusky or clearly necrotic. The tissue underneath might feel hard or woody, and crepitus might appear around this stage, days 4 to 5. This is when things get really critical systemically. The patient's blood pressure can drop dangerously, hypotension. They can go into septic shock. They might become confused, disoriented, or strangely apathetic.
Thinking through those stages really helps visualize the progression. And there was that specific anatomical variant mentioned too, Fournier's gangrene.
Yes, Fournier's gangrene isn't a different disease. It's just necrotizing fasciitis happening in a very specific and very dangerous location. The perineum, the genital area, or the perianal region.
Yep.
It's known for being incredibly aggressive and fast-moving in that area. It quickly leads to thrombosis, blood clots in the small vessels there, causing widespread skin necrosis. It's a pattern you absolutely need to recognize.
Definitely want to remember. So you suspect NF based on the clinical picture, the risk factors. How do you actually confirm it? What investigations are key?
Okay, so you'll start with the basics. Blood tests are essential. Full blood count, inflammatory markers like CRP and ESR, they'll likely be sky high. Chemistry panels to check electrolytes, kidney function, liver function, lactate levels.
Standard stuff for a sick patient.
Yeah.
What about imaging?
Imaging is really important here. X-rays might show gas in the soft tissues, which is a very strong sign. Ultrasound can sometimes help assess the tissues, but CT scans are generally better for showing the extent of involvement and looking for that gas or fluid collections along the fascial planes. MRI gives even more detail on soft tissue, but might take longer.
So gas on X-ray or CT is a big pointer.
A very big pointer, yes. Radiology can confirm that gas.
And there was a specific bedside test mentioned.
Yeah, the bedside finger test. It sounds a bit dramatic, but it can be useful. Under local anesthesia, you make a small incision over the suspect area. Then you gently probe with your finger.
Yeah.
If your finger passes easily along the fascial plane with little resistance, it suggests the fascia is necrotic, essentially disintegrated. It's highly suggestive of NF.
Right, and microbiology.
Crucial. You need blood cultures. You should take wound swabs, although they might just show surface bacteria. The most valuable samples come from surgery, actual tissue samples, sent for gram stain, culture, and sensitivity testing. That tells you exactly what bug or bugs you're fighting and what antibiotics will work.
Okay, but pulling this all together, the really critical point from the notes about diagnosis is what?
The most critical point is that there's no single definitive test that can quickly rule NF in or out with 100% certainty. You can't wait for a specific lab result or scan finding if your clinical suspicion is high.
Right.
Often, the diagnosis is ultimately made in the operating theater. High clinical suspicion should lead directly to surgical exploration. Surgery isn't just for treatment. It's often diagnostic, too.
That's such a key takeaway. Clinical suspicion trumps waiting for tests, which leads us straight into management. And the message here seems pretty clear.
Yeah.
Act fast.
Absolutely. The number one principle is immediate intervention. There's no time to waste.
It's a true surgical emergency. So what are the pillars of managing NF, according to the notes?
There are 3 core pillars. Immediate and aggressive surgical intervention. Broad-spectrum intravenous antibiotics started immediately. And comprehensive supportive care, usually in an ICU setting.
Let's break those down. Surgery first, the notes call it the cornerstone.
It absolutely is. Getting that patient to theater immediately for aggressive surgical debridement is the single most important factor for survival. Debridement means surgically cutting away all the infected and necrotic dead tissue.
And it's often not just one operation.
Rarely. Usually, patients need multiple trips back to the operating room for repeat debridements over the following days. The surgeons keep going back until they're confident all the dead tissue is gone and the infection is under control. It's aggressive, but necessary.
And then managing the wound afterwards.
Yes, after the debridements, the wounds are often large. They need careful management, usually involving daily dressings, sometimes under sedation because it can be painful. Later on, once the infection is cleared, options for closing the defect include letting it heal slowly, secondary suturing, or skin grafting. Vacuum-assisted closure, or VAC dressings, can also be really helpful in managing these large wounds and promoting healing.
Okay, so surgery is number 1, pillar 2, antibiotics.
Essential. While surgery removes the bulk of the dead tissue and bacteria, you need powerful antibiotics to mop up the remaining infection systemically and in the surrounding tissues. These need to be high dose, intravenous, and broad spectrum.
Meaning they cover a wide range of possible bacteria.
Exactly. You start them empirically, meaning you start them right away based on the likely pathogens before you have the culture results back. The notes suggest combinations like, say, vancomycin plus clindamycin plus meropenem, or maybe vancomycin, clindamycin, and ciprofloxacin. The exact choice depends on local guidelines, patient allergies, and the suspected source, like if it's type 3 from marine exposure.
And then you adjust based on the cultures.
Precisely. Once the lab identifies the specific bacteria and their sensitivities, you can tailor the antibiotic regimen to be more targeted. Clindamycin is often included initially because it can help reduce toxin production by strep and staph.
Got it. And the third pillar, supportive care.
Yes. These patients are incredibly sick. They're often in shock, losing huge amounts of fluid from their wounds, and due to the systemic inflammation. So aggressive fluid resuscitation is vital.
Makes sense.
Pain management is obviously a huge priority. They nearly always need admission to an intensive care unit or ICU for close monitoring of their heart rate, blood pressure, oxygen levels, urine output, basically, monitoring all their vital organ function.
And nutrition.
Really important, too. The body is under immense stress, breaking down tissue. Patients lose a lot of protein and fluid. So nutritional support, often starting with feeding through a nasogastric tube, is crucial to help them heal and fight the infection.
Okay, so recapping management for revision. Number 1, rapid, aggressive surgery. Number 2, immediate, broad-spectrum 5E antibiotics. Number 3, intensive supportive care.
That's the triad. Get those 3 things right, and quickly, and you give the patient the best possible chance.
And that directly impacts the prognosis, doesn't it? How well do patients do?
It varies hugely. The outcome really depends on several factors. How extensive the infection is when caught, how quickly the diagnosis was made and treatment started, how virulent or aggressive the specific bacteria are, and of course the patient's overall health and comorbidities beforehand.
But speed is key.
Speed is absolutely key. Early diagnosis and prompt aggressive treatment significantly improve the chances of survival and reduce complications. But even with optimal care, the average mortality rate mentioned in the notes is still around 20%.
1 in 5. That's incredibly high.
It is tragically high. And certain things make the prognosis worse. Any delay in diagnosis or getting to surgery, inadequate initial debridement, not removing enough tissue the first time, and underlying conditions like diabetes, especially if it's poorly controlled, or significant immunosuppression.
And even for survivors, the journey isn't over. The notes list some serious potential complications.
Yeah, the list is pretty grim and highlights just how devastating this can be. Beyond the immediate risk of dying from septic shock or toxic shock syndrome, patients face major local consequences.
Like
Extensive tissue necrosis, obviously, damage to underlying nerves and muscles, vascular occlusion, blood clots, cutting off blood supply, leading to ischemia, and even more tissue loss.
which often requires more surgery.
Almost always. Reconstructive surgery is frequently needed down the line, often involving complex procedures and skin grafting to cover the defects. And in severe cases, particularly involving limbs, amputation might be the only way to control the infection and save the patient's life.
That's life-altering.
Absolutely. And then there are the long-term effects: chronic pain, physical disability, lymphedema, and significant psychological impacts like PTSD or depression. It's a long road to recovery.
And didn't the notes mention higher mortality for certain types?
Yes, they specifically flagged that mortality can be even higher with infections caused by marine organisms, linking back to that type 3 we discussed. So ongoing monitoring, rehabilitation, psychological support, they're all crucial parts of the long-term care plan.
Okay, so this deep dive, really guided by these MSRA notes, has walked us through necrotizing fasciitis from start to finish. We've covered the definition, the types, the risks, how it works, what it looks like, how you investigate, and critically, how you manage it. And the recurring theme, the absolute key message throughout, has been the need for high clinical suspicion and immediate aggressive action, particularly with surgery. That's paramount.
Absolutely. We really hope that breaking down these notes into these sort of core high-yield chunks makes this pretty scary topic feel a bit more manageable for your revision, and hopefully helps you spot it faster if you ever encounter it in practice.
Definitely. Now, for more high-yield content like this, specifically tailored for MSRA revision, you can check out pastthemsra.com.
And remember, you can also get free MSRA questions and notes over at freemsra.com. It's a great place to start.
So as we wrap up this deep dive, here's a final thought to leave you with, based on everything we've discussed.
Yeah.
Given how quickly NS progresses and how much it can look like much less serious infections at the beginning, how do we as clinicians really hone that instinct, that sort of gut feeling that tells us, hang on, this might be more than just cellulitis, prompting decisive action without overreacting and subjecting everyone with bad cellulitis to major surgery? It's a real balancing act, isn't it?
It really is. Something to keep thinking about. Until next time.